Okay. So a wonderful good morning, good afternoon, good evening, depending on our location. I would like to use this opportunity to welcome each and every one of us to this important forum. By way of introduction, my name is Mohammed Mustapha. I am running my PhD here in Malaysia. So I am going to be the moderator for today's session. Actually, we've gotten a very important personnel in person of Dr. Ibrahim Dadari. Dr. Ibrahim Dadari is going to take us through a very important topic: vaccination data and research opportunities in low and middle income countries. You will recall that we normally have this kind of seminar. I think the last one we had seminar on E. coli. We had someone from the United States who gave us a talk on E. coli. It was very interesting, and because of some feedbacks that we received, it informed us to continue organizing such kind of conference. So by way of introduction, this is the agenda of the day. We're gonna have Dr. Saadatu Julde to give the citation of our guest speaker. Our guest speaker will take us through what he got. I'm sure we're gonna enjoy the discussion. Our guest speaker is Dr. Ibrahim Dadari. Dr. Ibrahim Dadari is already here with us. Dr. Dadari, you're welcome.
Good, thank you.
Yeah, so normally we used to allow the presenter to present. Then after the presentation, then we open the session for question and answer. During the course of the presentation, if you still have some questions, you can maybe for you think you may forget, you can put it down in the chat box. I have our president who is also available to assist to be checking the chat box. So we also have closing remarks by our president, Dr. Ibrahim Jato, and then we conclude by vote of thanks from Dr. Abubakar Shaban. So just to give a little background about what we do, who we are, our association is called Pharmacy Scholars Initiative, previously called Young Pharmacy Scholars. So this forum is a mentorship platform for pharmacists and other professionals with keen interest in research. The key thing is for that person to be interested in research. Once you are interested in research, our initiative is open and is always welcoming new members. The association was registered in 2017, and that's the first time it was founded, and then registered recently with Corporate Affairs Commission. I think during the registration, that was when we decided to change the name to Pharmacy Scholars Initiative. We have quite a lot of members from all over the world. We have membership from United States, United Kingdom. We have our president from Australia, myself from Malaysia. We have quite a number of members from Italy, from Turkey, and of course, a lot of members from Nigeria. So our doors are always open to welcome anyone that has a key interest in research. So what are our objectives? Our objective, we try to assist young researchers in conceptualization of research ideas, designing and conducting such research. So through this, we are able to publish quite a lot of papers in reputable journals through this collaboration. And of course, we try as much as possible to see how we can support young researchers in terms of scientific writing, grantship writing, manuscript development. This is what we normally do as a weekly event. Normally we have internal and external fora. The internal fora is like through WhatsApp. We have a WhatsApp group where every week we share knowledge on topics that are really, really interesting. So at the end of the day, we share and discuss educational resources. Recently, we were able to put together all our published papers into a compendium. And thanks to our the coordinator of the compendium, Dr. Basira Lawal Kankia, the current HOD of Clinical Pharmacy, Kaduna State University. She has done so well in putting together this compendium. So for anyone that is interested in going through such compendium, there is a website that we normally share our what we do, and of course, even this seminar is going to be recorded and deposited on the website. So feel free at any time to go through this website. We have quite a lot of resources. What we've been doing since 2017. If you go through this website, you'll be able to appreciate what we've been doing. So without further ado, I would like to invite one of our own member, Dr. Saadatu Julde, to give a citation of our speaker. Saadatu Julde, if you're available, you can share your screen.
Thank you very much, Dr. Mustapha. So, are you able to see my screen?
No, can you reshare it?
I've just shared it. Is the screen up now?
Yeah. Go ahead.
Yes, it is.
All right, thank you very much, Dr. Mustapha. I'll be giving the citation on Dr. Ibrahim Dadari, who is our guest speaker today for the quarterly webinar series that we usually hold. Dr. Ibrahim Dadari, MBBS, MHIMEP, CPH, MMP, FI, MC. So Dr. Ibrahim Dadari is the Global Immunization Specialist and Advisor at UNICEF Headquarters, New York, USA. He's the focal point for global urban immunization and the zero-dose agenda. He chairs the multi-agency urban immunization working group, which includes members like UNICEF, WHO, GSI, MBGF, USA, and Gavi, the Vaccine Alliance. He represents UNICEF on the IA 2030 Data Strengthening and Use Working Group. He also chairs the UNICEF Task Force on Utilization of COVID-19 vaccines and member of the joint WHO-UNICEF Task Force on the integration of COVID-19 vaccines into routine immunization and PHC, his prior professional roles. Dr. Ibrahim Dadari served as the maternal and child health specialist in UNICEF Pacific Office with jurisdiction to the Solomon Islands, Fiji, and he also extended technical assistance to several Pacific Island nations. He also served as a health specialist in implementation research and delivery service in UNICEF headquarters, New York. He was also program officer, EPI Health, EPI Logistics Specialist with UNICEF Pacific in Suva, Fiji Island. He was also a senior vaccine analyst and team lead with CHAI in Nigeria, where he worked on PHC strengthening. He also served as a research assistant with the TB HIV and Community Engagement Unit at WHO headquarters, Geneva, Switzerland. He was also a senior medical officer and medical officer in Nigeria in the National Hospital and Ministry of Health, Kaduna State. He also served as a guest lecturer at the University of Princeton, Public Policy course on Global Immunization and Equity. His education. He received his medical degree, MBBS, from Ahmadu Bello University in Zaria, Nigeria. He also obtained a master's degree in international healthcare management Economics and Policy from SDA Bocconi in Milan, Italy, with a specialization in global health and development. Currently, Dr. Dadari is a doctorate candidate in advanced practice leadership in public health with the University of South Florida College of Public Health. He's a certified public health professional. He's certified in public health and project management. He has had numerous advanced trainings in health emergencies, health systems, and epidemic intelligence from UNSW in Sydney, Jenner Institute, University of Oxford, Noguchi Medical Institute, Accra, Nosal Institute, University of Melbourne, and US Centers for Disease Control and Prevention. Some of his research: he published several peer-reviewed papers in quality journals such as Vaccines plus Global Health, Journal of Global Health. He is also a peer reviewer of journals including Vaccine, BMG Open, Journal of Health Economics and Outcome Research. He has widely traveled to over 25 countries, and he enjoys long walks, observing nature, greeneries, and swimming. Dr. Dadari is currently happily married and blessed with beautiful children. Today's webinar will be presented on the topic Vaccination Data and Research Opportunities in Low and Middle Income Countries by Dr. Dadari, which will be moderated by Dr. Mustapha Mohammed.
Okay, thank you very much, Dr. Jilde, for this wonderful citation presentation. So you all believe with me that this topic is coming at the right time. We are currently being faced with a pandemic and COVID-19 pandemic, and there is quite a lot of tension all over the world. So I believe Mr. Dadari from this citation has what it takes to inform us.
I'm having network issues now.
Okay, yeah, thank you, Dr. Jilde. I think we are done. We are okay. So I would like to invite Dr. Ibrahim Dadari to start his presentation.
Thank you, Dr. Mustapha. Thank you, President Jato and Dr. Julde. Thank you, esteemed colleagues. I've known a lot of you, I think, during training. Some are my relatives. And I also want to specifically say a shout out to, I think I have two persons who are joining from the Pacific Island, from Solomon Islands precisely, just because they wanted to also listen to this, even though I think it's past midnight over there. So without much ado, I'll just go. So I need permission to be able to share my screen, or maybe somebody should stop sharing. Okay, great. Okay, so I will try as much as possible to be very concise, considering the how wide this topic is, and also considering you are very distinguished persons. There's a lot of acronyms. I realize probably some of you are not very conversant with those. Those are some of the jargons we use in our field of practice, but I'll try as much as possible to explain. And wherever you see anything or any jargon, something, just note it so that I can come back to explain, because sometimes we get carried away as that's some of the language you often speak in our meetings. Okay. So we're basically going to look at vaccination data and research opportunities in low and middle income countries. Basically, this is the outline. I want to go through quickly the basics of vaccination, sources of vaccination data and description. We're going to look at the 2021 WUNIC data, the LQAS from Nigeria, the mixed data, and also what are the research opportunities. Okay, by basically, as most of you probably know, vaccination, of course, is the act of introducing a vaccine into the body to produce protection from specific diseases or ailments. And this helps to boost the body to develop immune response against this. So that's it. Vaccines could be part or whole microorganisms viruses, or in some instances even bacteria, live or killed, and also some proteins or toxins. And more recently, with the COVID vaccine, we've seen the use of nucleic acid mRNAs in the production of vaccines, like the Moderna and the Pfizer vaccines we have for COVID. Herd immunity, basically, this is basically the degree of protection a community has from the proportion of individuals who are vaccinated against a specific disease. You heard us, maybe some of you heard us, we're talking about polio outbreaks earlier. So once a community doesn't have sufficient population vaccinated or immunized against a particular ailment, they're likely going to have recurrent outbreaks. Just the same as, we have a lot of outbreaks in Nigeria, so, and other countries as well. It's probably because the herd immunity has not been achieved. And that is why we're looking at this vaccine data issue. Basically, for routine immunization, we look at the target population, which is the surviving infants or the newborn population per annum. So Nigeria, for instance, has a underwent population annual birth cohort of 7.5 to 8 million official statistics. But of course, some of us, when we look at the coverage and other indices, particularly from the north, we know that this is highly underestimated. And also for some specific antigens, we use surviving infants to calculate, while we use newborn to calculate, particularly the newborn vaccine schedules like BCG and hepatitis B birth dose. Okay, zero dose children. You hear us talking about zero dose children. So these are concepts that are used currently globally. In the vaccination series or schedule for countries, we have a DPT-containing vaccine, that is diphtheria, pertussis, and tetanus, and that could be in the form of DPT itself or pentavalent vaccine, which is DPT, hepatitis B, and Hib vaccine. So the first dose, which is usually given around 6 weeks in most low and middle income countries, is used as an index to measure whether children have commenced or have received any vaccine at all. And that is, so when children or the target, out of your target cohort, those that did not receive a single dose of DPT are counted as zero dose children. So basically, it gives us an index of our target that have not received any vaccine. Under immunized are those that have started. Basically, in this situation, they have received the first dose of DPT-containing vaccine, but have not received the third dose. So there are 3 doses for DPT for an individual to be fully immunized and protected. So once you start the first dose, you are expected to complete the 3 doses within a certain time, depending on the country. For Nigeria, it is 4 weeks interval between the 3 doses. So we use DPT-3 or DPT-3 containing vaccine coverage to measure the proportion of those that are immunized, and 1 minus that gives us the proportion of those that are under-immunized. Mixed communities. So basically, why we use the zero dose children as an index, because we've seen that it indicates multiple deprivation. And when we say multiple deprivation, we mean that these are clusters of communities or population where they are not only deprived of DPT-1 vaccine, for instance, they're deprived of other services as well. They lack nutrition screening. There's one-time malnutrition in that community. The that is water, sanitation, hygiene is very poor. And those are the things. When you look, for instance, in Nigeria, you look at some communities where you have large numbers of zero dose, probably you're going to see a lot of malnourished kids. You're going to see a lot of children not having access to quality education. You're going to see a lot of children not having access to sanitation, hygiene, toilet facilities, and clean water. So those are mixed communities, and we use zero dose children globally as an index to track those communities where we have children to multiple deprivation. Equity. Basically, this is a principle that has been, of course, as you know, equity doesn't mean equality. Equity is basically For those that have more needs, they get, so each community or each person should get proportional to what they actually need. And this is part of the principles of the IA 2030, the Alliance, and other global strategies. This is the Nigerian EPI schedule. When you see at birth, we have BCG, which is for tuberculosis, bacillus calmette-guerin, hepatitis B, the bed dose, and oral polio vaccine at birth. And then at different times of the schedule, 6, 10, 14 weeks, you see these are the vaccines that are currently administered according to the Nigerian EPI schedule. The DPTWP, that is what the DPT vaccine, or Penta, we call it. So it contains 5 antigens: diphtheria, tetanus, pertussis, Haemophilus influenza, and hepatitis B. And I think all the rest you are conversant with. So what are the principal sources of vaccination data for monitoring and decision making, particularly in low and middle income countries? So we have routine data collection systems. Basically, countries like Nigeria and some other 70+ countries use what we call the district health information system too. Prior to that, most African countries used the DVDMT, which was a WHO Excel-based tool that was used to collect routine monthly immunization data. So the immunization system has a well-organized data collection system where immunization coverage from the facility is aggregated at the local government or district level to the state and national level on a monthly basis. Then secondly, we have surveys that are conducted periodically. So some of the surveys are demographic and health surveys. I think Nigeria conducted one DHS in 2018. And then we have the multiple indicator cluster survey, which is one that Nigeria conducted more recently in 2021. But that was an amalgamated version with the National Immunization Coverage Survey. So you're going to see that's why I was referring to it as mixed next. Then globally, every year around this period of time, we've been busy the last 3 to 4 months trying to do what we call the UNICEF estimates of national immunization coverage. So this uses admin data. Each country submits data on the what we call the joint reporting form. And then that administrative data, which is usually getting from the routine system, and then we try to apply. I'll show you how some of the parameters that are used to calculate that. Okay. So last week we had the 2021 WUNIC data released. So basically by 15th of July of the next year, the complete immunization data for the previous year is released as that is the process of the WUNIC. So when the WUNIC basically looks at the joint reporting form, which is the administrative coverage reported officially by the countries, mostly coming from their routine system. And then we look at also the mix, all the surveys, the DHS that has been conducted, because we have a lot of issues with denominator data quality. So we try to moderate that with the survey data just to make sure that there's some kind of adjustments. And also look at other information like outbreaks, stockouts, those are stockouts of vaccines, and other data quality assessments that are conducted. And based on that methodology, estimates of national immunization coverage are published on global databases on WHO and UNICEF websites for access. So far we are having, I think, 196 for 2021 countries whose WUNIC estimates are have been provided. Of course, Nigeria is one of those. And this has been showing the progression of how the vaccine estimates, starting from very few antigens in 1999, BCG, DPT3, polio, MCV1, hepatitis B3, because these were the priorities then. And then now basically almost all the antigens or vaccine doses that are administered on the schedule are part of the WUNIC estimates process. So when you look at this, you see that we have an estimated 25 million children or infants in 2021 who did not complete their vaccination series. And that is an increase about 2 million more than in 2020. Basically, we are thinking that this could be attributed to the COVID-19 pandemic and its response. So when you look at the curve, you could see that the coverage has been improving slowly, and then it's reached a peak of 86% by 2019. And then the COVID pandemic hit, and then now we are back to 81%, which is around 2008, 2009 level. So there's a lot of recovery or restoration that needs to happen. In 2019, for instance, you could see we have 19 million under immunized, and also which has grown to 25 million. Part of those under immunized, we have those that are the 0 dose, which I defined earlier, which has been growing from 13.3 million. This is the number of children that did not receive any vaccine at all, and now it's about 18.2 million. This is showing by WHO regions. So as some of you know, we have UNICEF and WHO, we have regional offices. So each countries are clustered under regions, and this is showing. Most often, West and Central Africa has a large chunk of 0 dose and under immunized. You could see in 2021, 4.4 million children in West and Central African region did not complete their immunizations schedule, and that is the largest, 24% of all 0 dose children in the world. Top countries, 0 dose. India is 2.7, and then Nigeria is 2.2. India came up because of the COVID pandemic, but before that, Nigeria was topping the lead. I believe that is a wooden medal, not a golden medal. So Nigeria consistently has very high numbers of 0 dose, and that is, I think, thanks to some of our social factors, particularly in the northern part of the country. Measles, the same thing. You see Nigeria, in fact, is leading with 3.1 million children that are unprotected from measles. But of course, you have other countries. Indonesia, for instance, has been doing very well. They just popped up in 2021. And we think it's because of their concerted efforts at COVID vaccination, so at the expense of routine immunization. But otherwise, in 2020, Indonesia did not feature in the top 10. We are seeing countries like Myanmar coming up because of the conflict. So each country probably has some reason why they are here. But for us, I think for Nigeria, consistently they've been there, and the DRC also has been there consistently. DRC has one of the probably worst immunization coverages in the world. Their COVID vaccine coverage is less than 10%, as at the last time we spoke to them. So basically, this is the same 0 dose children data, still saying the same information in a different way. Yeah, so same thing, measles. So when you look at, these are snapshots from the WHO and UNICEF estimates of national immunization coverage. You could see for 3 vaccine doses or antigens. The ones you see the red asterisk, those are the national estimates, and then the blue line is the administrative data. So you could see some kind of alignment or coalescing of the data between the national estimates and the administrative data that the country submit, because often for between the red asterisk, so the admin, and then blue is the national estimate. So often what we have for Nigeria is that the admin data reported is usually higher than the estimate, and that has been proven consistently when you look at the routine immunization coverage, and then you look at the survey data. The survey data is usually the coverage are much lower than what countries report. Okay, let's look at the 2021, what they call the Program Assessment for Performance Management and Action, Lot Quality Assurance. This is a kind of survey that the National Primary Healthcare Development Agency does just to try to monitor routine immunization coverage in the country as part of their improvement process. So this is basically the methodology. They pick in each local government 6 health facilities using probability proportionate to size. And then in each health facility, they choose 6 settlements because, as you know, each health facility under primary health care and routine immunization has catchment population or catchment communities. So those 6 settlements will be picked from those catchment communities. And each of those settlements, 10 households are randomly selected. And each household can now look for infant children to be able to check their vaccination status. So this is just showing the structure of how that is chosen. Okay, so this is a summary of the number of lots that were expected and those that are sampled in the Q for 2021 LQAS. So this is showing also the settlements that were included in the LQAS. So you could see the performance. Mostly you see when you look at northwest, north central, around Niger, Kaduna, and perhaps this probably aligns to the areas of insecurity as well. You could see the performance is not so encouraging. But then we have a lot of green areas that are performing well. But that also does not align very well with the survey data that we have, the mixed NICS data that we have. So this is the LQAS coverage is still showing is high relative to the mixed data. One of the explanations that we got from the MKCDA is that they've done a lot of improvement, but then we see there's a decline in the national immunization coverage. And that is one of the reasons we have the UNIC estimates to be able to realign and provide a more realistic and robust immunization estimate for the country, which could be used for decision making. Because when you see a country presenting very high coverages, 80, 90%, you expect that the outbreaks should be low. You don't expect to see a lot of, as they call it, circulating vaccine-derived polio, CVDPs. You don't expect to see measles outbreaks. You don't expect to see whooping cough or pertussis. But once you're seeing that, it's telling you that something is wrong. And this could be data quality issues, or it has something to do with the denominator. If the target population is ideally supposed to be, for instance, 1 million, and you're using 500,000 to calculate your coverage, then something is going to be wrong. Because by the time you reach 250,000, you think that you've reached 50% of your population, but in actual reality, you've only reached 25%. So that is some of the things that are happening in that country. For those that reported not receiving vaccines, these are some of the reasons they gave. A lot of people are focused on trying to survive. They didn't have time to take their children to the clinic. Some say vaccines are not available, so probably due to stockouts or there's no clinic close by. Some are not even aware. And we have a lot of social attitude norms, or should I say, disbelief, vaccine hesitancy in that part of the country. And I think there's a paper we wrote in 2011 or 2010, which was looking at the polio scenario, which was boycotted initially, with people coming up with flimsy ideas that people, it's just truncate our population, girls are not going to deliver. And we've seen a lot of those girls that were vaccinated then now having twins and triplets. So those are the kind of myth and misinformation that is being spread. Okay, let's look at the mixed NICS. The mixed NICS was done in 2021. So MIX is the multiple indicator cluster survey. And then the NICS is the National Immunization Coverage Survey. So this is embargoed data, not yet public, so it's still being crunched, finalized, so it should be ready, I think, in the second half of this year. So when you look at the DHS, for instance, if we look at specific antigens, measles containing vaccine, MCV1, for instance, you see it has 54% in the 2018 DHS. Penta1, for instance, you could see 65.3%. In 2018, DHS, Penta 3, 50.7%. So there has been some improvement. For instance, MCV1 moved from 54 to 60. So things are improving slowly. Penta 1 moved from 65 to 70%. Penta 3 moved from 50.7 to 56.4. So there's some around 4 to 6% improvement in the coverage of antigen. But at this level of 50s and 60s coverage, we are not near the herd immunity. And that is why we consistently have the outbreaks. And largely, this improvement, when you look at the dispersion or the spread, basically, this high coverage is mostly from the southern part of the country. The north is abysmally low. In fact, we saw a state like Sokoto had a coverage of 8%. And people were wondering how to address that. But I don't think we have time to go in depth into those issues. Okay, COVID-19 vaccine updates. So, about 10.7 billion doses have been administered globally. And you can see, this is as at February 28, 2022. The green areas are, what do you call them? Those that have sufficient vaccination of COVID. And then this, you see, largely Africa, you have the red and the maroon or orange looking areas, which is showing suboptimal vaccination. When you look at the legend or the keys on the left, it's less than 10 persons vaccinated with at least one dose per 100,000 population is red, and then greater than 70 per 100,000 per 100 population is considered green. So that's basically 70% coverage. So you could see Nigeria, I think, just was able to cross the 10% coverage threshold just recently. And myself, I was shocked why we couldn't have reached more than 10%. But it's not surprising, considering a lot of factors around which we are very conversant with. And this, well, luckily, the burden of COVID perhaps has not manifested a lot in those countries. But if the burden was comparable to the other temperate countries, then it would have been very devastating. Okay, now, research. Our country and sub-Saharan Africa is doing very, very poorly in research. And I think to my colleagues who are joining from the Pacific as well, I see it's not better in Papua New Guinea and the other Pacific Island countries. So our papers published are very poor, very low in terms of proportion. Perhaps partly, I think, is due to the quality of journals we produce. We have a lot of journal publications, maybe that are not considered of acceptable standards, are not Scopus index, for instance. So if they use those Scopus index to measure that, then perhaps we don't have a very low publication rate. And that cuts across Africa. As compared to the Chinas, the Indias, and the United States of this country, where you have a very high research output. So this gives an opportunity. And when we look at the immunization space, for instance, we see a lot of publication coming from those visitors and others from foreign nationals. So that is why this data issues that we presented to you will give you an opportunity to be able to look at a particular area of interest and decide to do some research. There's a lot of opportunity in it. So to guide your research, just to know that IA 2030 we're talking about, it's the immunization agenda. This is the global immunization blueprint for till 2030. It defines what we aim to achieve globally for vaccine. So the vision is a world where everyone, everywhere at every age fully benefits from vaccines for good health and well-being. And then we have, these are the different components from demand, coverage and equity, life course and integration, outbreaks and emergencies, supply, sustainability, research, and innovation. Supply, particularly supply security, I think that is a very interesting area for persons, like for pharmacists as well, immunization supply chain. And I think we have some colleagues who here work on that, and perhaps they could provide some additional guidance as well. So this is how, these are some of the goals that we use to measure success for the 2030. Looking at the impact level, for instance, we're looking at preventing this disease, promoting equity, building strong systems. So we're doing a lot of estimation of lives saved, vaccine preventable disease outbreaks, looking at the zero dose agenda, looking at life course integration, universal health coverage. So all these are areas that we could explore in terms of research at the national and subnational level. For instance, you could look at measles, could take vaccine security, you could look at vaccines administered, how that has impacted in terms of reducing outbreaks and all those zero dose communities. Those are all interesting areas. Yeah, okay. So we have the equity reference group. The equity reference group for immunization is a global think tank of immunization stakeholders and experts who basically have the interest or focus on equity. And this is co-chaired by the Bill and Melinda Gates Foundation and UNICEF, but membership from the World Bank, from WHO, the Gavi, they're all part of the equity reference group. And based on crunching of publication or evidence, it's been identified by the ERD that there are 4 priority areas of work, which if we work on, perhaps we're going to reduce inequities in vaccine administration and delivery. And these are the remote rural communities, the urban poor, those affected by conflict and gender, and the gender barriers. Remote rural, we consistently know there are a lot of issues in remote communities. How we've been trying to do outreaches and campaigns to reach these communities. Urban poor, this has been a fairly new area. And this is an area, of course, which I chair the Global Urban Immunization Working Group and other relevant urban immunization. So in this area, we have all the urban poor communities. When you look at the settlements, urban settlements that are cropping up so fast, like they're not part of the normal demographics that are calculated in terms of target population. There are a lot of issues in terms of some actually unofficial or what should I say, communities, illegal communities or illegal settlements. I think one typical example is the Makoko communities inside the Atlantic in Lagos. Those are people that are living, the government does not accept them living there, so perhaps doesn't provide sufficient health facilities to be able to provide them with primary health care, immunization, and other services. Conflict, we have a lot of communities affected by conflict. In fact, a significant chunk of zero dose is actually in conflict affected areas. And you could look at the Northeast, for instance, and parts of the Northwest where we are having this conflict. These children are not reachable, perhaps because health facilities are damaged, security areas cannot be accessed because they're under non-state actors or they're under warlords in some countries. The Tigray region, for instance, in Ethiopia, cannot be accessed because of the conflict issues. We have other countries, Yemen with 2 governments, for instance. One part of Yemen does not even accept some of these things, and the other part accepts. So those are the kind of complexities that are existing. Then gender barriers, as we know. I know we are very passionate about gender issues. And I think I urge colleagues to also try to understand and learn more in terms of gender. It doesn't mean that men and women are equal, or not, but they're looking at making services, essential services, or all services actually should be accessible and be available to both sexes. It doesn't necessarily without discrimination, and also to be able to support caregivers, be them men or women, to be able to take their children to access vaccination. But we know there are a lot of norms around that are hindering that and contributing to more zero dose and underimmunized children. Okay, when for the zero dose agenda, we have the IRMA framework. Basically, this is identify, reach, measure, and monitor, and the advocate. So these are different components of trying to reach zero dose children and mixed communities with vaccines and other essential services. So identify is basically who, where, why. How many zero dose children are there? Reach is designing strategies to reach them. Monitor and measure, basically monitoring and then quantifying, and also using evidence to advocate. So these are some of the, so you could hear some of this IRMA. So this is some of the framework that you could actually use in terms of doing your research and focus on a specific area to do your research. We have something we have called the Gavi Learning Hubs. So Gavi, Global Alliance for Vaccines and Immunization, as it used to be called, but now it's branded as Gavi the Alliance, is working or investing in developing country learning hubs. And countries including Nigeria, Somalia, Bangladesh, and one more country are going to have country-specific learning hubs. So I urge you to try to explore more on this and try to see how you can align and collaborate with these learning hubs to be able to do some, be it implementation research or evidence synthesis around zero dose mixed communities and under immunized or under vaccinated children. Basically, the learning hubs have three key objectives: diagnosis and tailored approaches, evidence generation and use, and timely monitoring and use of data. So this is basically the schematic of the theory of change. You will have time to go through it later. So when you look at the learning priorities, you could look, for instance, these are some of the research questions that could be of interest. Identify where we actually talked about where the zero dose children are. You could look at in Nigeria specific location, how to find the zero dose children. Are there actually really zero dose? We say there are some myths and misconceptions in terms of social demographics. So you try to look at that as well. You look at what are the approaches. Maybe the approaches that we are using to deliver these vaccines are not the most effective for those kind of communities. We try to explore the effectiveness of these approaches using implementation research or other forms of evidence generation. You could also look at the supply chain. I know a lot of you will be interested in vaccine commodity logistics and security. How effective is that? How is that contributing to reaching zero dose? Or how is that contributing on the negative dimension to more zero dose children? So those are some of the things you could look at as well. I know a lot of you know about implementation research. Just basically, it's the integration of research within existing health programs, implementation policy making cycles to improve program outcome. So basically, the approach is try to measure or use some proven intervention, try it and see how that can be scaled. So there are a lot of opportunities. I see the alliances for implementation research. I think one is led from somebody from University of Benin, but try as much as possible to explore opportunities. And these learning hubs are actually going to do part of it, a lot of implementation research. Then we have another parameter is integration of COVID-19 vaccine into primary healthcare and routine immunization. So as it is now, a lot of the COVID vaccination is being given as a standalone program, but for sustainability, for to leverage resources as well as due to the epidemiological challenge we're having, it has to be integrated into routine immunization and primary health. So you could look at opportunities to study integration, how effective is that, whether it's visible, it is not, what are the implications when we integrate in a country like Nigeria, how would that look like? Is it going to positively or negatively affect the routine immunization coverage and all this kind of thing? So, and whether it actually going to contribute to sustainability, whether it has actually resources are going to be leveraged, or it's going to be another, I don't know, opportunity to misuse the resources, to say. Okay, then it's good also in your research to try to learn what a lot of organizations are doing. For instance, you have specific research agenda you could link up with persons like me working in UNICEF or persons working in WHO. Bill and Melinda Gates Foundation also funds a lot of this learning and research. Also have an office in the country, USAID, part of the global partners we work with. JSI also does a lot of work in terms of that path. There's also another research organization. We work with them to test a lot of tools and guidelines. The Global Fund, which primarily focuses on TB, HIV, and malaria, also supports a lot of research as part of the system strengthening. And Gavi Alliance, I don't know how I missed Gavi on this slide. Gavi, the Vaccine Alliance, has specific funding. They're funding the learning hubs. They're interested in case studies. Just yesterday, I think I was talking to a particular consortium or consultancy firm in terms of they're trying to apply for a response to a request for proposal to measure the contribution of various initiatives funded by Gavi Alliance to Zero Dose agenda. So there are a lot of opportunities that we could leverage. We don't need to stick to the traditional university available funding, but we try to reach out to some of these agencies and try to scout the internet to see when there are opportunities from these organizations, how we can collaborate, because it's a win-win situation. It gives us the opportunity to expand our horizon to do more research. In the interim, also gives us the exposure that is needed in terms of our career and professional growth. So these are some of the resources that you could find time to read to understand more in terms of these different parameters or methods I talked about. Thank you so much.
Thank you very much, Dr. Ibrahim Dadari, for this informative and wonderful presentation. I could now see how we are somehow left behind in terms of information. I think some of this immunization and vaccination data are already deposited somewhere, but this forum has been able to provide that information clearer to most of us. I'm very sure some of the graphs may be confusing, but I'm very sure that quite a lot of people would find time to have a closer look when the material is ready. So yeah, the session is open for questions and answers. If you have any question, you can unmute yourself and introduce yourself, then you ask question to Dr. Dadari.
I think that is from Abubakar Sani, if he has raised his hand. All right, go ahead.
Okay, good afternoon, everyone.
Good afternoon.
My name is Abubakar Sani. I worked as the Assistant State Logistic Officer for routine immunization and vaccines in Bauchi State, Nigeria. And I currently work as a clinical pharmacist in FMC Azure. Thank you very much for the wonderful presentation, Dr. Dadari. I really have interest because I worked as an Assistant State Logistic Officer for routine immunization in Bauchi State. So thank you for the presentation. I have question and comment. My first question goes like this. You made mention of WHO, UNICEF, that's the UNAC method of gathering the information with regards to vaccine coverage, the RI coverage globally. So I don't know if at your own end, you are using some data from EVMA, Effective Vaccine Management Assessment, that was conducted, I think, in 2019 at Lagos, because I was opportune to attend the training in Lagos for the EVMA. So we are about to start the EVMA assessment. Then COVID-19 came in, but I know that it took place, I think, last year. So I don't know if you use part of the data from EVMA in trying to find your data in the UNAC method. That's question number one. Then question number two, with regards to integration of COVID-19 with RI, I know almost all our RI antigens, the Penta, hepatitis, MCD, yellow fever, and others, I know they have similar storage condition of 2 to 8 degrees Celsius. But I know for COVID-19 has different temperature of storing, because I could remember we were opportune to be supplied with the COVID-19 storage facility in Bauchi. It's very, very expensive, and the temperature is very, very different from, because a temperature is under negative. I do remember the exact temperature, but it's different from those of RI vaccines. So don't you think there will be challenge with regards to provide, because if we try to integrate the COVID-19 with RI, how do we tackle providing the storage facility to most of our health facilities, considering the fact that the COVID-19 has different storage condition with RI? Then the last one is the comments. So you made mention of the research. I actually like that, because I could remember there's this organization called Global Good. They established an application called VARO. We use the VARO to track the status of our cold chain equipment across the state. So Bauchi State was the first state in the whole globe to be piloted with that Global Good, and I was the focal person. So I even presented on that VARO application during the last TechNet that took place. I presented on the Global Good VARO application during the last TechNet that took place in Brazil. So because both, we actually, during our undergraduates, especially those that read BPharm, we were not taught basics of research. So for that reason, for the fact that we lack research basics back in undergraduates, I couldn't use that data from VARO to make publications. So had it been in our university, students are taught research basics, we'll have means of doing our research at our own disposal. So thank you for the presentation. I really appreciate, and I congratulate you once more. Thank you, sir.
Okay, thank you, Pharmacist Abubakar Sani, for this input and question. I'm sure Dr. Ibrahim has already had your question and will address it if he's ready now.
Yeah, shall I respond, or you want to collect more questions?
Yeah, I think better respond.
Okay, great. Thank you so much, Pharmacist Abubakar Sani. I think this is very interesting, and you see me smiling. I'm really excited because I want to see people not only doing stock in the hospital, but also doing being part of the practice. This shows that you're part of the practice. UNIC estimation, the WHO UNICEF estimates of national immunization coverage. As you know, if you saw on the slide I showed in terms of methodology. Okay. Sorry, let me just quickly go to that if I can find it. Okay. So you can see that we're looking at stockouts of vaccine availability information. Yes, the effective vaccine management assessment, part of it may contribute to the estimation, okay, but it's not a key parameter. As you know, the EVMA is looking mostly at the logistics side. It's looking at the security, waste management. It's looking at stock availability. So those are more of the outputs in terms of the logistic arm of immunization than the outcome. So most of the coverage data we're estimating are outcome indicators. But yes, it contributes. When you see stockouts here, And stock out, or stock availability is one of the parameters in effective vaccine management assessment. So yes, it contributes, but in terms of the latest one, it has to be finalized to be part of this. So for instance, we're having discussions before this UNIC data was released in July 15th, so some few weeks back. And one of the points that was raised was actually Nigeria has a mixed NICS 2021, which I probably shared 2 slides here. And we're saying the country it might insist that this has to be captured, but if it's not officially available, it cannot be used as part of the process, because you can't use data that has not been officially released to do a global estimation or of data that is going to be available. Exactly. So that is that. But yes, all those are captured in, but they have to be, the processes have to be followed. If the EVM is finalized, so for the next year, 2022 data, which should be published in 2023 July, perhaps we can look at that to see if there are major stock issues that could also affect the estimation. The next one, you talked about storage. Yes, for the integration, we had very interesting discussions in terms of integration of COVID-19 vaccines. And these are some of the key discussions we've had. But just for you to note and for listeners to know that only few vaccines are actually stored outside the +2 to +8 degrees Celsius. That so most of the COVID vaccines actually are stored at +2. So when you look at AstraZeneca, Johnson and Johnson, for instance, those vaccines are stored at the normal vaccine storage temperature of +2 to +8 degrees. The ones that are stored at the ultra cold chain temperature, which is -20 to -70, Pfizer is -70 degrees Celsius, Moderna is -20 degrees Celsius. So Moderna can actually fit in, because polio vaccines at the national storage level, where we store it for 6 months, or the regional store, depending on the country, where they store it for up to 6 months, they could actually freeze polio vaccine, for instance, at -20.
Yes, that's
so exactly. So in that situation, you can actually align Moderna vaccine and polio in that situation. But for Pfizer, but for Pfizer, which is -70, and that is why a lot of those ultra cold chain equipment were provided. So one of the questions of interest was that, how are you going to maintain this ultra cold chain even after COVID vaccination? So those are some of the areas you could actually look at it, do some implementation research, provide some. Nobody really has response. If COVID abruptly stops, we could try to see how we repurpose those ultra cold chains or storage of lab related supplies or specific specimens. That could be an opportunity in strengthening the lab capacity of the country. But we're suspecting that the scenario we are using in terms of the integration discussion is that COVID will subside, but then it might behave like a flu, needing periodic boosters. So in that case, we're likely going to still need those ultra cold chain to store some of these things, and then we can maintain stock. But otherwise, if COVID, which is what we wish, if COVID completely stops, then you can repurpose it for other lab storage. You talked about the global goods, and I'm very happy to see that you've gone as far as presenting to TechNet. But I think, as you said, there is no support for research, and that is why I think you have a lot of eminent researchers here, including the chair of the panel, of course, and all of us. So you could easily reach out to colleagues, say, this is what you are proposing, you want to write your paper on this, and I believe colleagues will be able to help out. There are probably some research courses here and there that people could be able to share online, but I think the best form of support for research is to tag along with somebody who has already done that. In that way, you easily build your capacity and you'll be able to see how. Because now you presented in TechNet, but we need you to try to make sure you document under your name that such that in the future it can easily be referred to that pharmacist Abubakar and colleagues actually publish this information global goods. Otherwise, somebody will do it later in another country on global goods after 3 years from this time and claim that it's the first time. There's no evidence to say that you actually started. So
yes,
those are some of it. Yeah. So you could try to reach out and see how we can help you. I hope this is helpful.
Okay, thank you very much. Thank you very much, Doctor, for presentation.
Yeah.
Okay. Thank you very much, Dr. Ibrahim, for this response. I would like to call on Ibrahim Yahya. Ibrahim Yahya, can you unmute yourself?
Yeah, good afternoon all.
Good afternoon.
I would like to start by congratulating Dr. Dadari for this presentation. I have one question and a comment. The question is, how can we improve our data? Because most of the data we collect, you discover we have issues with either those people that are generating or collecting the data. Some of them are just there to collect the data anyhow as they wish. Some of them feel they are just being forced to collect the data, and that will actually affect the data generation and invariably also affect our research. So what can we do about such things to improve on our data collection? Then the comment goes to the last pharmacist, Abubakar, that made mention of research, that they were not being taught research from their undergraduate studies. Though I'm not in lecturing field, but I know I want to disagree with that. Undergraduate students are taught on research, but I believe, yes, there is a gap between the research undergraduate students do and what is obtainable in practice. There is a missing link in that, but they were taught. That was why they did projects, and they were taught basic of research. But once you come out from school, it's left for you to build your own capacity in research. And we are talking about research, even at postgraduate level, you discovered most of the lecturers are not grounded also in research. So that actually affects the research from most of us. And the only way to go about is
I think
Dadari said you can also hear is having mentors or having research groups, but with this to start of us that were out there practicing in either hospital community, we are floating on data that we don't even know what to use it for. So I believe we could form research groups and start from there. Thank you.
Thank you very much, Mr. Ibrahim. I would allow Dr. Ibrahim Dadari to respond to Mr. Ibrahim.
Thank you so much, my namesake. Yes, in terms of, I agree with you. Starting with the last point, research group is very important. And I think this kind of platforms with the lots of capacity I see around could help to organize such research groups, provide the opportunity and mentorship needed to be able to support people. As you said rightly, there's a lot of data floating out there. But that data has to be harnessed and used for the maximum benefit of the society. And I think that is something we need to focus. Yes, there are limitations in terms of the research trainings provided, but then people should also look out for opportunities. There are a lot of free courses on research that somebody can join. There are a lot of webinars, I think I see online opportunities also, when you mingle with professional groups, there's a lot of opportunity. But I think this group could look at that just beyond supporting lectures to be delivered, but also trying to see how mentorships can be organized to support people back home to be able to do research, publish their research, and present in different fora, as well as share materials. In terms of how to improve data collection, yes, data quality is an issue, not only for research purpose, but also for the health systems as well. As you see, that is why we have the unique estimation, just to try to address some of the data quality issues. Data quality audits, for instance, have been done periodically to look at the quality of administrative data. In some cases, I remember, I think polio, they used GPS to track vaccinators and recorders to make sure that they actually went to where they said they went to give these vaccines, and also to record. So there are a lot of tools that could support that. I think we just need to see how it's just like trying to address some of the issues we face. We try to see how we can leverage technology as well. But the key thing, I think, is proper design of the methodology, keeping in mind that these things are there, these risks are actually there, and also plan to mitigate those risks. Over from my side.
All right, I think it's very clear. Thank you so much, Dr. Dadari. I would like to call on Aminu Kuba. If Aminu Kuba is there, you can unmute yourself and ask your question.
Thank you, Dr. Mustapha, for the opportunity, and congratulations to Young Pharmacists Group, scholars, for the focus and good organization, and to Dr. Ibrahim for a wonderful presentation. It's really very rich. So I have a question for Dr. Ibrahim on COVID, especially being at the highest level of policy concerning immunization. Do you think the investment Nigeria especially, or sub-Saharan Africa is making on COVID, do you think it's worth it? Considering that from your presentation, the COVID has interrupted a lot of health services. Can you hear me?
Yes, I can hear you.
Can you hear me?
Yes.
Yes. So the first question is, considering the resources that are being pumped into COVID vaccination in Nigeria and other sub-Saharan African countries, do you think it is worth the investment vis-a-vis the losses we have experiencing, especially on routine immunization on other health services? Then secondly, I worked in Sokoto as a vaccine security and logistics consultant for 3 years, or almost 4 years. We had Sokoto was for the mixed NICS survey. It was 3.7 or 3%, 3.4%, I think. That was the 2016, 2017 survey. Now that Sokoto has gone up to 8%, at least that's more than 100%. So you should clap for us. We have moved. But on the more serious note, I think if this is a comment, I think the challenges we have in northern Nigeria is focusing on immunization in isolation of other development indices like literacy, poverty, and other indicators. That makes it difficult for people to even understand what immunization or other health interventions are. So I think we should be a bit, what do they call it? At policy level, I think we should focus more on we should have a more integrative approach to these issues than just focusing on one particular thing and expecting it to change. Because I wish the young pharmacy scholars, I wish someone will be able to look at, I know there are a lot of published data on that, but specifically to Nigeria, the relationship between literacy rates and attitudes to health care or health-seeking behavior of the population. And unless we address the root causes, I don't think we are going to see any significant change. Thank you.
Okay.
Thank you so much.
Thank you very much, pharmacist Aminu Kuba. Dr. Ibrahim, you can respond to.
Thank you, pharmacist. I mean, yes, you're very right. Let me start with the second one. Yes, we can clap for you for improving the coverage from 3 to 8%, but still, I mean, 8% is terrible. It baffles. Just to tell you, it baffles. In fact, some colleagues, they had a mission to Nigeria, and after they came and just met me and said, how is it possible that a state has 8% coverage? So they were thinking of what exactly to do. But as you said, there are a lot of issues. Focusing only on routine immunization is probably not the solution. And I think it's more of a fire brigade approach, working with the little resources that are available. A lot of the discussions we've been having is trying to see how we use multi-sectoral approaches to address that. And that is why you have the concept of the mixed communities, using the 0 dose as an indicator of mixed communities. But then when we look in there, we're going to see issues with literacy, we're going to see issues with child protection, we're going to see issues with hygiene, sanitation, malnutrition, and a lot of those things. And if those things are not addressed, it creates a kind of suspicion in terms of the kind of services that are being delivered. Yes, that is the situation. But the challenge we're having is, I think there are a lot of issues with respect to governance that needs to be addressed, because these are basic services that should be addressed by the respective governors. And as you know, working in the development sector, usually you have funding for specific initiatives, and that fund cannot cut out for everything. So I think that is, it's between the devil and the deep blue sea, trying to see how to survive in this kind of scenario. But you're absolutely right. Focusing on one intervention is not the best solution, but more of looking at integrated approaches, multi-sectoral approaches. But then we talk about the resources to do that, the commitment, the government commitment to do that, and interest. In fact, we're speaking to DRC, and they say no, they actually prefer to have vertical campaigns. Why? Because health workers have not been paid in DRC for at least 8 months. No salary. So their incentive was to keep campaign. They do yellow fever campaign, finish, and then get some per diem. They move to measles campaign. Rather than having an integrated, they say no, because that is how they survive. So there are a lot of systemic issues that actually contribute to this that needs to be addressed. But yeah, but I think we take it piecemeal. And congrats for improving the coverage. In terms of investment, the COVID investment, that's a very good question, actually. People are wondering, why invest so much on COVID vaccine at the expense of routine? And I think the routine, the low performance, the routine coverage was probably not anticipated, because people thought that the routine immunization and PHC is very robust. And in fact, initially, when we had some discussions with some stakeholders, they were skeptical that that really happened. But now there is clear evidence that yes, there has been an impact in terms of the COVID pandemic itself and the response on routine immunization. And I think, in fact, my project is looking at that in, I think, Kaduna and Kano, to try to do into the proper micro assessment of how, to what extent that actually impacted. When you look at the world globally, yes, it is worth it, because once the world is a global village now, once you have COVID still circulating in one community, just like we had in the beginning of this discussion, I think pharmacist Abubakar was talking about, Abubakar from Lilongwe was talking about congratulating us for having COVID polio in New York. And that is what we see when we fail to protect or vaccinate communities to have herd immunity in certain parts of the world. Why do we have COVID? Why do we have polio, vaccine-derived polio coming into the United States? It's because in some other parts of the world, it has not been contained. I remember very bitter experience, I think in 2015 when I went to Hajj. They lined us up in Jeddah International Airport and they were dropping polio drops in our mouths because of where we came from. So it has implications. Yes, when you look at it at the micro level, at the national level, it might not have. But when you look at it globally, in terms of the way the world has changed, we can't escape it. So, and that is why it's easier. Since it's safe, effective, it's better people have the vaccine and save us some of this embarrassment that we face than to allow us to continue facing some of these things. And I agree with you. Yes, the consequences were probably unintended. They weren't actually envisaged, I think. People were overestimating the strength of the routine immunization and PHC system. But now they know. And in fact, the last SAGE, that is the statutory advisory group of experts on immunization, our recommendation was to focus on recovery, catch-up vaccination to make sure that those communities that are missed are reached with vaccines. Over. Thank you.
Okay, thank you very much, Dr. Dadari, for that response. I would like to call on Pharmacist Ibrahim Shehu to unmute himself and ask his question. Pharmacist Ibrahim Shehu. Okay, I will call Abubakar, Dr. Abubakar Isa. Dr. Abubakar Isa, if you are with us, you can unmute yourself. So I think maybe they are not close. I saw a question on the chat box.
Hello.
I think we are done with, because there is no any new question from what I can see.
No comments in the chat box.
Hello.
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 Hello. There's a question from the chat box, I think, from
I think
Mustapha, which he says after thanking the presenter, and he was saying what a community do to help the health workers in reaching to zero vaccine areas, as the government is not ready to provide vaccine to such areas. If I understand his question, is thinking about all those remote areas where possibly the health workers are not able to reach, or the government is not supporting them to reach. So in such condition, what is the way forward?
Yes, thank you. And I think that is a very interesting, and we've been trying to encourage communities to actually own and support this. The same way people organize iftar, for instance, fasting, or organize special support. People could actually organize maybe community groups that are existing could try to see how they can pull in health workers and support them to actually deliver these services to these communities. A lot of the constraint that part of the constraint, we know part of it is accountability, but also part of the constraint is resources. In some communities, for instance, they've organized themselves to see how they could transport their pregnant women in labor to hospitals so that they reduce maternal mortality. We could have communities that could actually organize themselves to pull in health workers from the catchment facilities on specific dates, mobilize communities to see that services, primary health care, and of course, immunization is administered to these communities. Awareness session. This, for instance, a forum like this or other community groups could pick up a particular week and say, this is an awareness session. We want to make people understand people should ask questions and clarify, because a lot of it is sometimes it's misunderstanding. People don't even understand what is different between a vaccine and a medicine. They think that I'm not sick, why should you give me? Because they see it as, they think it's a drug, not knowing that it actually give it to a healthy person to prevent the person from getting sick. So these are some of the questions, and this is compounding with the low literacy in this community. So organizing sessions, awareness sessions, outreaches with campaigns. There are, in fact, some communities, they adopt community. Pharmacist Ibrahim Dadari, for instance, could adopt his locality in Kano and say, okay, I'm going to monitor the immunization coverage in this community. I'm going to work with the primary healthcare facility serving this catchment and support them with awareness to see that the same way we support them maybe to build their religious capacity, but also we also support them to become healthy. I think those are some approaches that could be utilized as well. I saw one Samuel had a question. Does he want to come in? You want to allow him to come in? This Samuel. Wow.
Okay,
Okay.
yes.
If Samuel is online, he can unmute himself. But it's like he's talking about, he wants you to speak more on the index you mentioned, which affects the transition of research conducted in Nigeria and SSA into journals.
Oh, okay. So basically, it's about the research, the quality of platforms or the journals we publish in, right? There are. I had a course just to look at Scopus Index, for instance, to see specific persons in terms of research they do. It depends. If the journal, for instance, the journal you're publishing in is not indexed in a lot of these indexing platforms, and to be indexed in those platforms, the journals have to meet certain criteria. So it's about quality, right? I know in the academic system in some of our places in low and middle income countries, let me not just say Nigeria, we try to look at just publishing for publishing's sake to meet the numbers. But we also have to be cognizant of the quality. And I understand there are some constraints that people mention in terms of maybe publication fee, right? Not all high quality journals actually. You could have, your paper might not necessarily be open access. There are some that have concessions for publication fee. There are some specific journals, you contact them, they tell you research that is conducted in low and middle income countries, you pay nothing. So they are there. It's just for us to explore, take a step forward. Don't be too comfortable in our zones and feel that I just want to publish in Kaduna Journal of Health, for instance. Just giving an example. I don't know whether it exists, but look at it globally. There are PLOS journals. There are Lancet. Don't underestimate the capacity. As long as your research is well thought through, the methodology is robust, they can actually be accepted and published in those journals. I think that is it. First, look at the quality journal before talking about publication fee and all that. And you can actually make a case and say, sorry, I can't pay this. There are some researches I did. Of course, I can pay, but I say I make a justification. This research was done in low and middle income country, and we need a concession in terms of the publication fee. And they agree because of the quality of publication. So that is how people should look at it rather than get scared from the beginning.
Thank you very much, Doctor. I think we have exhausted all the questions. Even though I saw one last one, he's requesting if you could emphasize on gender and immunization focus in Africa. I think it is one of the raw areas for research.
Yeah, it is. It is. Okay, so gender, basically, we're looking at mostly it is the roles, not the sex per se. It's about the roles of individuals. How does the role of being a housewife, a mother or a father, or even a housewife, a caregiver, affect children or communities having access to services? It's basically about rules. And the roles are defined by the norms of the society, right? Society has specific structure, they have specific expectations that need to be aligned to be able to do this. And fine. Basically, the gender aspect, we're looking at how do communities work comfortably while meeting their social obligations in the community, still be able to access. For instance, we could have a situation where they say women are not allowed to move alone. Why don't fathers accompany the women to the facilities? And that has been tested in some Muslim countries. The fathers are saying, oh, let's go carry your wife and go to the clinic with the kid. For the fathers, there's nothing stopping the father from taking the child to get vaccinated. If the society thinks that, you understand, the society thinks that, no, the woman cannot go out, or all those kind of things. So there are a lot of things that are being tried in different places. And that is why when you look at it, for instance, we had a lot of webinars of recent, consistently, one factor that is coming, I'm also a Muslim, one factor that is coming out as a modifier or a regressor in a lot of the analysis is being a Muslim in some of these countries. You look at Muslim as a regressor that is being used to regress and look at whether it has an impact. And in a lot of these countries, it actually has. So if there are specific issues of being a Muslim, how do we address it? And this is one example. Yes, the woman said in those communities might not be allowed to go alone. The father can also take the child to the clinic. They could organize women, health workers to actually come and organize outreach. So there are a lot of ways going around that rather than outright rejection. And then these communities persistently are faced with outbreaks. The only two countries that are still polio endemic are Afghanistan and Pakistan. And that tells you a lot. I'm not going to say anything, but it tells you a lot. Exactly. Nigeria was there, was a third country, and just went out last 3 years. But still, we're still having circulating vaccine-derived polio viruses circulating. And why Nigeria couldn't eradicate polio, we know, was contributed largely from northern part of the country. And we know why. So there are a lot of these social norms that we face them. We shouldn't dismiss them and say, no, this doesn't exist. No, there's no. Let's acknowledge these things are there. But then let's find local solutions that could help us to achieve the service delivery while also respecting our social norms. I think that is the way to. In the past, we've been defeatist around it. We say, no, they're fighting those coming from development. They say, no, you must do it this way. And then the local community are resisting. I say, no, you cannot impose your decision. No, there are different ways of doing it. We can look at how we accommodate local customs and still deliver. I think that's by and large. And some of those, we call them transformative gender approaches and all those things. Over from my side.
All right. Thank you very much, Dr. Dadari, for this response. I would also like to thank you specifically for taking out your time to come and share this knowledge with us. We hope anytime, next time we can be able to reach out to you. Your doors are open and you'll be able to continue to contribute to our cause. Thank you so much. I think the next item on the agenda is we have a closing remark from our president, Dr. Abubakar Ibrahim Jato. So if Dr. Abubakar Ibrahim Jato is here, the floor is yours.
Yes, I'm here. I hope you can all hear me. I'm Ibrahim. I'm here from Hobart in Tasmania, Australia. Well, this is a very interesting and educative webinar, and I can say this is one of the best webinars we have in recent month. And I would like to, on behalf of Pharmacy Scholars Initiative, to thank our guest speaker, Dr. Ibrahim Dadari, for a wonderful presentation. The presentation was very relevant and comprehensive, I would say this. No doubt it's coming from an expert and a policymaker. To summarize the presentation, there were so many data and so many information shared. Because of time, I don't have to overload our participants with information. We have some information overload experts here. Please don't query me. So the lecture, he talked out so much about countries with high rate of zero dose children. And unfortunately, my dear country, Nigeria, is among the top in the two categories of those who had zero dose and those who are unprotected. And at the same time, I will congratulate my country again for crossing over the 10% coverage. At least we deserve some, some applause. Also, I would like to talk more on the research opportunities, because that is where our Pharmacy Scholar Initiative is all about. And like he said, there was a low research output in Nigeria. And this is not something that is surprising, because at Pharmacy Scholars Initiative, that is what we started. So at the beginning, we think, why we have so much low research output from Nigeria? We have so much data, why the output is low? And that's what initially prompted us to organize this Pharmacy Scholars Initiative, to address this very large gap of knowledge. So we just organize ourselves and see, let's see what we can do in order to tackle this giant problem. So we started with like a research to find out the background. What causes this low research output? And I could remember Dr. Zayan Shitu was the lead research group. And what we found out is there's lack of motivation. Like people feel like they are not motivated to conduct research. And there's lack of awareness. Like they are not even aware why they should conduct research. And then another one is they just feel like it is difficult to conduct research. If I conduct research and publish, then what next? Especially if I'm not in the academia. And the last, which is almost has been a major reason for us in Nigeria, is funding. Those think that any research is related to funding. So if nobody's giving me money to do research, I'm not doing it. So these are the things that we put in the paper and we get it published. And I'm very happy that now we have so many people who like in the two ends, like we have the experts and those handling the data. And before going there, I would like to update the participant that at Pharmacy Scholars Initiative, we're able to conduct 3 research. We published them, and those research were on COVID and COVID vaccine. One of the COVID vaccine paper was led by Kasim, which we tried to let people know about low vaccine rates in African countries. What was the reason? And I'm glad to inform you that all those papers has been hosted by the WHO Global Literature on COVID. And now that we have most of us, or some of us here, are editors in most of the bigger journals, and we have people who sit on data, and we have policy makers. And at the center, we have people who are very enthusiastic in research. That is Pharmacy Scholar Initiative. So I'm just suggesting, I think we have everything at hand. The next thing is just to venture into the research. So I'm suggesting, is this something that we can formulate an international vaccine research group here? We have data. Kuba was suggesting, my friend Abubakar Sani from Bauchi has data, and I'm very sure most of people like Abubakar Isa definitely has some data. We have policymakers. Ismail is an editor. We are all experts in research. What next? And we have the enthusiasm. We have the motivation from the webinar. Dr. Dadari has already gingered us. So what next now is just to put everything together and hit the ground running. So I will on behalf of Pharmacy Scholars Initiative, I would like to make this suggestion that we should create because I call it international because most of the research members are coming from in different continents. So that we can have a research group from here. And the research group will look into this data we are sitting on it and how we can bring this data into one place and approach journals to make it published. And if this is accepted, then we can start from this day, 24th or 23rd of July. And I think since we have an expert, publishing it in a quality journal will never be a problem. And I'm sure these guys from USM, they can really take care of the APC funding. So that's what I'm suggesting. So it's up to the guest speaker. We are suggesting this to you. If you are happy for this, then at PSI, we are solidly behind this, and we will really be sure that this research has reached so many milestones. So that is from my own end. So before going to the next agenda, I would like to get a response from the guest speaker. This is our proposal on behalf of PSI. You people are in the Helm of Affairs, so many data there. And we have my friend Abubakar Sani and so many other people like Ibrahim Yahya. He just said it that like that data, but people doesn't know how to use it. So it's like we have the raw materials, we have the machines, we have the fuel and everything, the power. All what we need now is to streamline the process and make it running. So, Mr. Guest Speaker, what would you say on this request?
Yeah, thank you, Pharmacist Jato. I think it's a great idea, and yeah, while you work and you need to work out the details, but I will be happy to support you as much as possible with this. Thank you.
Okay, thank you so much. Pharmacist Shaban, I need your support on this. What do you say?
Yeah. No, good evening once again, everyone. This is a wonderful suggestion, really. But if you can read between the lines, you can see that Dr. Dadari has already given a green light, because he within his talk, he already highlighted a gap. You know, he gave an example of a gap that exists and is possible, you know, that is researchable, like looking at the relationship between literacy rate and health-seeking behavior and things like that. You know, so these are the things that we have to be able to merge between the two. It's easy for someone like the policymaker to identify a gap. Okay, this is the gap, and then then the researchers will go, you know, how do you provide a solution? We come up with the, what do you call it, with the protocol on how to do the research, you know, and things like that. So I think it's something very good. And then implementation research is one way to go about it. So I think we have everything at hand. It's just like he said, he throws the ball back to us. We just need things like just bring up the group, you know, and then, for example, we delegate responsibilities, build on the protocols, and then that is it. I think is a very, very good initiative, inshallah. So we are ready to do that, inshallah.
Okay, so to wrap up this, I think Professor Ismail, they have conducted a similar research on global burden of disease or something like that. So Dr. Dadari has so many data from globally, and he knows some focal people that we may reach out to. So I'm just suggesting if you can have something like a global thing, that it would be a very comprehensive thing. And then we now map it down to local, maybe to Nigeria, or it's up to us anyway when we start strategizing the research at maybe the administration process. All right, Merote, thank you so much. And thank you so much, Dr. Dadari, for accepting this request. And I will reach out to you. And anyone who would like to join this new initiative, I'll post my email, and I also post, okay, the email of our PSI is there. So please, if you want to be part of this initiative, please drop your name and your email address, if possible, with your phone number, so that at the end of this webinar, we can see where we can move ahead. Thank you so much.
Thank you.
Thank you.
Okay, thank you so much, Dr. Ibrahim Dadari, for this wonderful closing remark. I would like to call on Dr. Abubakar Shaban. Dr. Abubakar Shaban is going to give a vote of thanks. Dr. Abubakar Shaban, if you are ready, vote of thanks, and probably we have some token of appreciation, even though, yeah, very little to present to our guest speaker. Dr. Abubakar Shaban, if you are here.
Yeah, okay.
Go ahead. Thank you.
Yeah, thank you very much, Dr. Mustapha. Okay, at this juncture, I would like to thank each and everyone for attending this this special gathering. And I believe, as I also gained a lot, many people, or all of us, have gained a lot from this webinar. So I would like to specifically thank people like from the various immunization supply chains, various international groups, people from different geographical locations that have, you know, spent their time. And then this, I'm happy with their enthusiasm, really. So finally, I think, just a minute, okay. Yeah, so I would like to, on behalf of the Pharmacy Scholars Initiative, I wish to present this certificate of appreciation to Dr. Ibrahim Dadari for this special day, for this special webinar, as being our special guest speaker. Thank you very much, Dr. Ibrahim Dadari.
Thank you. This is incentive based.
Yeah.
Thank you. I really appreciate this opportunity
Yeah.
to actually
Yes,
share with
and
you.
yeah, thank you very much for that. Looking forward for future collaborations and future endeavors. And then the next will be also like to present the certificate of appreciation to Dr. Mustapha Mohammed for his outstanding contribution as the moderator for today's webinar. Thank you very much, Dr. Mustapha.
Thank you very much, Dr. Shaban.
Yeah, okay. Inshallah, we will send your certificates through your emails. Thank you very much. I think due to time factor, we are already now, I think, some minutes to 4. So I'll hand over to you, the moderator, if there's anything. Thank you very much.
All right. So thank you very much, Dr. Abubakar Shaban. So we have come to the end of today's presentation, and I would like to specifically thank all the people that were able to join. I'm sure people connected from different parts of the world, from Nigeria, from the US, the UK, you know, Malaysia. So we really appreciate you coming and joining and participating in this webinar. So we look forward to see you again in our future programs. So just keep checking our website. We normally update our website in case we have any upcoming program. You will definitely see it on the website. So we thank you all for coming and have a nice day.
All right. Thank you so much. Bye-bye.
Thank you.
Thank you so much, Doctor.
Yeah, have a good day.
All right. Thank you very much.
Thank you.